Okay. All right, chapter 9, guys, is the most important chapter. Once we're done with chapter 9, you will have your next exam on 7, 8, and 9. 4 major categories of joints. Of course, we're going to start off talking about that. This chapter right here, joints, you have a lab exam on this particular chapter. Joints are the most important aspects for your profession. Whether you are trying to be a coach, a PT, an OT, a nurse, you're going to have to know your joints, and you're going to have to perform them for me, because it is my job to make sure you know your joints. Okay? A joint, of course, is a point of contact where 2 bones actually meet. Okay? I can't go to the next slide. Okay. Joints protect, link the bones together. We talked about a couple of them in chapter 8, the atlanto-occipital joint, the atlanto-axial joint. We're going to talk about the rest of them over here. You have a radial-ulnar joint, humeroscapular, just to name a few. They link bones of what? The skeletal system. They allow for movement to take place. The movement that occur with joints, of course, involve your muscles. So this will be a dual exam that you guys will perform. You're going to have to perform the actual movement. You're going to have to tell me which muscle is contracting or is involved in the movement. Permits effective movement and protects what? Softer organs, like your thoracic cage, organs like your heart, your lungs, and things of that sort. So joint anatomy and movements will provide a foundation for the study of what? Muscle actions. Those range of motion, well, the movements that you're going to be doing, those are actually called actions. We do them every day: flexion, extension, internal rotation, external rotation, and muscles, as I stated before, allows you to do that. So you're going to have to understand the action of the muscles in conjunction with the movements. Okay. Another name for joint, of course, is articulation. Whether or not the bones are movable at that interface, any point where 2 bones meet. Some are movable, some are not as movable as others. We're about to talk about that when we talk about the 4 major categories of joints. Arthrology, science of joint structure, function, and what? Dysfunction. We're going to talk about some dysfunctions over here: rheumatoid arthritis, osteoarthritis, of course, with some dysfunctions we're going to talk about. Kinesiology, of course, muscles and skeletal, which, of course, you will be doing for me when you perform the movements. The study of the muscles and the bones or the skeletal. It looks at the mechanics of the muscles in your joints or the biomechanics of it. Joint name, as I stated, derived from the names of the bones involved. Glenohumeral joint. What 2 bones are involved when you see the term glenohumeral? Glenohumeral. Glenohumeral. Huh? Yeah, what part of the scapula? Yep, the glenoid cavity and what? The humerus, right? You guys just had a bone exam, right? Where you talked about the, you had to know the glenoid cavity, right? So you have the glenoid cavity with the head articulating with the head of the humerus. It's also called the humeroscapular. Those names mean the same thing. It's just the humerus and what? The scapula. Radial-ulnar. Radial-ulnar. What 2 bones? The radius and the ulnar, right? Allows you to do pronation and supination. And, of course, we all know atlanto-occipital, right? What 2 bones? Yep. The atlas and the occipital what? Bone. Okay? Atlas and the occipital bone. So, they're classified according to the manner in which the adjacent bones are bound to each other, with differences in how freely the bones can what move. Here are your 4 major categories. That's question number 1 on your study guide for chapter 9. Bony, fibrous, cartilaginous, and synovial. This latter one, we're going to spend most of the chapter talking about this 4th one here, because this one is the most complex of them all. Here, your synovial joints, these are your freely movable joints, okay? These are the most debilitating joints, your synovial joints, like your MCPs, your IPs, elbow, the shoulder, your hip joint. This is where people get arthritis, okay? Very crippling, the synovial joints, okay? So the rest of the chapter will deal with the 4th category. Okay, so another name for bony is synostosis, an immovable joint formed when the gap between 2 bones is going to what? Ossify, which means it's going to fuse together, okay? And it's going to become a single bone. I don't know, remember the other day I had the fetal skull up here? And there were like 2 mandibles. They had what? 2 frontal bones right here on the fetal skull. Frontal and the mandibular bones of what? Infants, okay? This is an example of a bony joint because this suture right here, okay, has to fuse together, creating what? Just one what? Frontal bone, okay? Remember, this is just a lot of membrane, fibrous membrane or connective tissue that's separating the 2, the frontal bones. It's called a metopic suture. The same thing with the mandible. It looks like they have a right and left mandible because this bone has not completely what? Become one or what? Ossified. Cranial sutures in the elderly. Okay. The sagittal suture, here. Okay. As we age, instead of it's like you're having 2 distinct right and left parietal bones. This right here, the sagittal suture, of course, is going to fuse, becoming one. And it's going to be like you only have one parietal bone. Cranial sutures in the elderly. The first rib is another example of the bony joint attached to what? The sternum. With old age, it's going to fuse actually with the sternum during old age. Okay. The 3 classes of fibrous joints are listed on page 280 of your textbook. The suture, gymphosis, and syndesmosis. Know the alternative name for fibrous joints and the 3 kinds. 3 kinds are figure 9.2. Another name for it is what? Synostosis. Or this says synarthrosis. It's supposed to be synostosis. Okay. They make a lot of errors with this book. But anyway. Fibrous. Here are your 3 kinds. A point at which adjacent bones were bound by collagen fibers that emerge from one bone across the space between them and penetrates into what? Another. You have your 3 kinds that are listed here. We know sutures are immovable joints. There are different types of sutures. You have your serrate, your lap, which is called your squamous suture, and the plane or the butt, which is just a straight line right here. They're showing you the first example, serrate. Interlocking wavy lines. Those were your 4 what? Sutures that we talked about with the skull, coronal, the sagittal, the lambdoid, and what? Your squamous suture. Okay. Well, squamous is a lap. Overlapping beveled edges with the squamous suture. Okay. overlapping between, if you look at your squamous suture, it's kind of overlapping between the temporal bone and the sphenoid bone. There's also an overlap between the temporal bone and the occipital bone. Of course, there's an overlap between the parietal bone and the temporal bone if you look at your squamous suture. So if they're actually relating it to wood on page 281, dovetail joint, a middle joint, and a butt what? Joint. Okay. Plain or butt straight, the palating process in the roof of your mouth. Remember we talked about, I think on your exam, the intermaxillary suture, of course, which is this little part right here in the maxilla, of course, is a straight or a plain or butt what? Suture. Gymphosis, fibrous joints, attachment of a tooth to its what? Socket. You can see the collagen fibers here. Remember, we're talking about a connective tissue over here. You can see the collagen fiber actually expanding from the jawbone to what? The tooth. These little, these are called your periodontal ligaments here. Periodontal ligaments, of course, is what holds the tooth in its what? Its socket. There's going to be a slight amount of movement over here when it comes to this particular type of joint. You can actually sense how hard you're biting on food because this joint is going to allow your teeth to move a little bit. Also, you know, when you have popcorn kernels stuck between your teeth, all right, because there's going to be a slight amount of movement. If these ligaments, you probably heard of periodontal disease, right? When these ligaments starts deteriorating or getting really, really thin, that's when people get periodontal disease. If the disease gets really, really severe, that ligament has actually what? There's no support between the tooth socket and the jawbone, and the teeth will what? Fall out. Okay? Allows the tooth to move a little under the stress of what? Chewing. Okay? That's a periodontal what? Ligament. Syndesmosis is a fibrous joint in which two bones are bound by longer collagenous fibers and in a suture. Interosseous membrane. There are two locations on that skeleton where you're going to find an interosseous membrane. Where are they? This is where you're going to have two bones that are going to be parallel to each other. Huh? The ulna and the radius. And where else? Tibia and the fibula. Exactly. You're going to get a little bit more movement here. Spanning between the ulna and the radius, you have that little interosseous membrane. All it is connective tissue. Okay? If you look at the tibia and the fibula, same thing, right? This one, they're showing you what? The tibia and what? The fibula. Fibrous connective what? Tissue. The interosseous membrane unite the radius to the ulna, allowing what? Supination and pronation. Less movable, the tibia to the fibula. You don't get a lot of movement in your lower leg, but we do a lot of movement with the bones in the forearm or the antebrachium, right? Which would be what? The radius and the ulna. So one of the movements that you guys will be doing for me, of course, will be pronation and supination. Okay? And when you do pronation and supination, the radius is going to kind of pivot over. It's called the pivot joint as well. It's going to pivot or glide or slide across what? The ulnar, and it's going to create sort of like an X. Okay? Now you're in what? Supination. When you go back with the palms facing forward, they're now parallel to each other. You are now in what? Well, this is supination. And this is what? Pronation. Okay? This one is more movable than the tibia and the fibula. Okay, two types of cartilaginous joints. You have synchondrosis and what? Symphysis. You guys should know that because we've talked about it enough over here. Synchondrosis and what? Symphysis. Bones are bound by what? Hyaline cartilage. First one was on your test the other day. Wasn't there a question about hyaline cartilage on that quiz I gave the other day? Yeah, hyaline what? Cartilage. Okay. Cartilage, of course, what part of the bone will you find cartilage before the plate actually closes? Epiphysis, exactly. Temporary joint in the epiphyseal plate and what? Children binds the epiphysis. And what's going to happen? We know that when all of the cartilage is gone, that plate is going to close and it's going to leave behind what? A line. First rib attachment to your sternum, of course, will fall under the category of sin. When you think of chondrosis, guys, think about cartilage. So if you see that term on your test, chondros, and if you see hyaline cartilage or cartilage as one of your choices, please mark it. Okay? Costal cartilage. This is the first rib. The first rib actually fuses with the sternum. So they're showing you rib 1 in the costal cartilage and how it's connected to what? Your sternum. Pubic symphysis, where is that located? And why do we have it? We've talked about that one before. Where is it over here? The pubic symphysis. Can anybody help me? Where, Jonathan? You can just tell me. Yeah. So it kind of holds the hip bones together, right, or the pelvis, the right and left. Right there in the center, that little plastic that you see is called what? The pubic what? Symphysis, okay? Two bones joined by what? Fibrocartilage. Now, remember we talked about fibrocartilage in chapter 5. Okay, where else will you find fibrocartilage? What is it called? Between the vertebrae. You're absolutely right. What do we call it? Between the vertebrae. Intervertebral disc. You see the little plastics? Remember, that's where you get the herniated disc. Because inside of that intervertebral disc or your ID, you have what? A gel-like substance. And when you crack, or that nucleus pulposus is going to what? Come out, and it's going to put a lot of pressure on what? When you have a herniated disc. Remember I told you guys the other day. It puts pressure on what? When people have pain. Why do people be in so much pain when they have a herniated disc?
It puts pressure on the nerves.
The spinal nerves, exactly. And what? The spinal cord, right? It's a lot of pain. Redness, inflammation. Okay, bodies of your vertebrae and your intervertebral what? Disc. You're going to get a slight amount of flexibility going on with the vertebral column or the vertebral what? Canal. Okay? Fibrocartilage. Uh-oh. The hardest one. These are called diarthrotic joints or diarthrodial joints, joint in which two bones are separated by a space called a joint cavity. This one is pretty complex. I think this picture, study figure 9.5. Yeah. That's on your test, okay? Figure 9.5. And look at the complexity of it. They've taken your proximal and your middle phalanx and that space between your proximal and your middle. Remember I was telling you guys these are joints? You have your proximal, your middle, and your what? Your distal, right? Between the two that allows your phalanx to bend like that is because of this what? That joint. So between your proximal and your middle phalanx, guys, you have this joint cavity right here. Inside of that joint cavity, guys, you have this lubricating fluid called the synovial fluid that has to feed the cartilage that's left at the distal end of the bone, which is called what? When the bones start growing, there's cartilage left where? And what type of cartilage is it? I'm glad I'm giving y'all a test on this. Huh? Karen? Articular cartilage. Remember they called it hyaline cartilage in chapter 5. Remember at the distal end, remember initially the entire, before this is bone is what? Cartilage, right? And the only thing that's going to be left over is cartilage where? At the distal ends of what? Each joint, which is called the what? articular what? Cartilage. There is a reason for that cartilage being left. It decreases the friction between the joints. It makes the joints what? More movable. Those joints have to be lubricated by way of what? Your synovial fluid. If you lack articular cartilage, that means the synovial fluid cannot circulate. That means your joints cannot be, I call it oiling of the joints, okay? Nutrients can't enter your joints. Weights can't be removed from your joints. And, of course, no articular cartilage, completely gone. You're going to get bone spurs that are going to occur right here. Between these two bones, there's no cartilage. And there's going to be friction because bone is going to be rubbing up against bone, aka rheumatoid what? Arthritis. Most are freely movable. If you ask anyone, I think your textbook talks about it, to describe any joint or point to any joint in the body, they're going to probably point to those freely movable joints. The synovial joints. The shoulder, the knee, the elbow, the fingers, the hip. Well, you don't move the hip that much, but it's a synovial joint. Okay, so articular cartilage, exercise and articular cartilage, very, very important. Okay, like I said, that's why warming up before you work out is very, very important, because what's going to happen is when you're warming up, that articular cartilage, of course, is going to start bringing in a lot of the good stuff. It's going to be like a sponge. It's going to swell, and all that synovial fluid is going to come into it. Okay, but the moment you start exercising, and warming up is important because it decreases your chances what? Injuring your joints too. So exercising is important. If you don't exercise regularly, or if you don't have a regimen of exercising over time, that cartilage is going to deteriorate. Remember, you lose what you don't use. Some of your joints probably right about now are probably aching at such a young age. So, because there's not enough nutrients and oxygen and things of that sort that need to feed your joints to keep them more mobile, so they won't feel stiff like they're locking up on you sometimes. You know what I mean? That's for you young folks. Most likely to develop painful what? Look at bullet number 2. Where are the PTs and the OTs in here? The athletic coaches. You will know this before you walk out of here. In order to represent Lawson State Community College well. Nurses, pre-nursing students, you will know this. Okay? Fitness trainer. I will not want anybody training me at a gym that do not know the biceps, the triceps, the joints, and things of that sort. You know what I mean? Or the muscles. Their mobility makes them important to what? The quality of life. Page 283. The most familiar type of joint is your synovial joint. Ask most people to point out any joint in the body, and they're likely to point to a synovial joint, such as your elbow, knee, or knuckle. Many synovial joints like these examples are freely movable. Others, such as your joints between the wrist and the ankles, bones between the articular processes of the vertebrae, have more limited what? Mobility. Don't move that much. They're most structurally complex type of joint and are the type most likely to develop uncomfortable and crippling what? Dysfunctions. Old sports injuries. Those guys in high school have those injuries, Professional football players, years later, those injuries can develop into arthritis. Okay? They are the most important joints for such professionals as PT and OT, athletic coaches, nurses, and fitness trainers to understand well. You will understand them well in here, or you will come back to see yours truly. Their mobility makes the synovial joints especially important to the quality. Reflect, for example, on the performance extremes of a young athlete, the decline in flexibility that comes with age, and the crippling effect of what? RA. The rest of this chapter is concerned with what? This. The most complex of them all. Synovial what? Joints. Now, this is why they're complex. Look at the general anatomy of that joint. Articular cartilage, okay? You have a cavity. You have your synovial fluid. You do need to know what your synovial fluid is. It's called, it has the consistency of albumin, which is an egg white. Know which joints from there. I don't have a lot of information from this chapter. We're going to talk about that ACL and PCL. Albumin, and you know, the body makes hyaluronic what? Acid. It's slippery, kind of, it lubricates what? The joints, nourishes the articular cartilage, okay? So when you're working out, you're doing Zumba or whatever you like to do, and you're putting compression on those joints, it's getting rid of that waste. It's like squeezing it like a sponge. Waste is coming out. So you'll be a little bit more flexible when you're doing Pilates and all of that, and you're running on the treadmill, you know. That's a good thing, right? But the moment you take that pressure off, what's going to happen? That articular cartilage is just going to suck in all the good stuff. And then your knees won't be stiff. You'll be able to get up off the floor and won't have to ask someone to help you up, or you won't be grabbing onto a nearby chair or whatever at the age of 21. You know what I mean? You get the picture. Make sure you read about exercise. Clinical application on page 284, FYI. Okay. When synovial fluid is warmed by exercise, it becomes what? Thinner and more easily absorbed by what? The cartilage, right? Okay. Because you want it thin, guys, so it can circulate more freely and quicker into the joints. You don't want it all thick and, you know, kind of like syrup or molasses, okay? The cartilage swells and provides a more effective cushion against compression. For this reason, a warmer period before vigorous exercise helps protect the articular cartilage from undue wear and what? Tear. Protects you from injuries. You know? If you're going down further, when weight is taken off the joint, when you're done with exercising, okay, with your Zumba, the cartilage absorbs your synovial fluid like a sponge, and the fluid carries oxygen and nutrients to what? The chondrocytes. What are chondrocytes? Cartilage cells. Without exercise, what happens? Articular cartilages deteriorate more rapidly from inadequate nutrition, oxygenation, and what? Got all that buildup of waste. For those of you that don't exercise, just waste inside of the joints. Okay? Right, Megan? Look at Megan looking at me like, whatever. Makes movement of synovial joints almost what? Friction free. Knees won't lock up on you. Synovial membrane. Now, your synovial membrane is what actually secretes that synovial fluid. And macrophages, we know what macrophages are. Those are your big eaters, right? Your white blood cells that remove what? Debris. You want that. You want that when you work out, okay? Moving on. In a few synovial joints, fiber cartilage grows inward from the joint capsule. It talks about your articular disc as found between the temporomandibular joint. Temporomandibular joint. What two bones are articulating here? Jonathan? Yeah. So we talked about the radioulnar, the radius and the ulnar. Sternoclavicular. Acromioclavicular. The acromion and what? The clavicle. Where is the, which bone is the acromion located on? Scapula, right? Which one is it up here? Is it this one, the right, or the left? It's the right. Really? It's this one, right? The flat one. Because the clavicle goes like that, right? Okay. Which one is this one? Coracoid process, right? Okay, good. Meniscus. I'm looking for my knee joint. Now I want to tear that knee off, that femur over there. Behind. Has anybody had a torn meniscus? It's common in athletes. Well, I cannot find a knee. Can I borrow somebody's knee joint? No, I'm just kidding. Here you have it right here. Right here, this little crescent-shaped part right here is your meniscus, okay? You have what you call a medial and a lateral meniscus right here, which is behind. A lot of times, athletes, when they have a torn meniscus, if it's really severe, they have to come in behind here where this little crescent part is, and they have to scrape the cartilage off. That's what it is. But the knee, guys, is a shock absorber. In the knee, two cartilages extend inward from the left and right, but do not entirely cross what? The joint. So it's that little part that's found between what? The femur and what? Your tibia. But this part right here is your meniscus. The medial, you have a medial and a lateral. The medial meniscus, of course, that's the one that's most commonly injured, as opposed to the lateral meniscus or menisci. Okay? Got bones across each other, improves the fit between what bones? What two bones? The femur and what? Your tibia. Stabilizes the joints, reducing the chances of what? Dislocation. Now, if you've got, I was watching the news about a week ago, and there was this little boy. Looks like you may have been, I don't know, maybe you guys saw it too. Maybe 6th grade. Has torn his ACL already at such a young age. You're going to have some problems when you get to be my age. But they were just saying how to prevent tearing the ACL and how important it is to have a warm-up period. You know, and they were wondering if the coach was actually letting the kids warm up prior to them actually playing. But another thing with exercising, which you guys are going to have to know, those quadriceps right here, they get so strong, and that tendon from your quads kind of goes over this knee part, this part right here, and it connects on the shin bone, stabilizes it. And it decreases your chances of dislocating your what? Your knee. So when you stand up, your knee won't give out on you. The trick knee, you know, sometimes people stand up, they what? They fall. So you're going to have to know your quads and all of that, which is very important. But we get into more details about that. I was kind of looking. That knee is pretty complex, guys. The knee joint. Page 301. Tibiofemoral. What does tibiofemoral mean? What two bones? The tibia and what? The tibia and what? The femur. Okay, a tibiofemoral, the knee joint, is the largest and most complex diarthrosis of the body. It is primarily a hinge joint, which we're going to talk about because you can only flex and extend what? The knee. But when the knee is flexed, it's also capable of what? Slight rotation and lateral gliding. The patellar ligament also articulates with the femur to form a gliding what? Patellofemoral joint. What's a patellofemoral joint? What two bones? The patella and what? The femur, right? Okay. Now, if you go on down, second paragraph. These are extensions of the tendon of the quadriceps femoral. Is talking about the lateral and your medial patellar retinacula. Quadriceps femoris. All of these 4 big old quads in the front of your thigh. Strongest muscle in the body. Okay, these muscles are the large anterior muscle of the thigh. The knee is stabilized mainly by the quadriceps tendon in front and the tendon of the semimembranosus, which is one of your hamstrings that you're going to have to point to me when you do your synovial joint movements on the rear of the thigh. Developing strength in those muscles reduces the risk of what? Knee injury. But if you don't have strong quads and strong hamstrings, how do you get them? Exercising, right? Working out. Right. Right. Then they go on and talk about the C-shaped cartilage called the lateral and medial what? Meniscus. And I don't think they show the knee joint. Well, yeah, they do show it on page 304. Looks like a little cup behind your kneecap. You have the lateral meniscus, and you have what? The medial what? Meniscus. If you read knee injuries and arthroscopic surgery on page 305, I think it talks about your meniscus and how it's one of the most commonly injured joints among athletes, as well as the ACL, which is your anterior cruciate ligament, right? Your accessory structures are your tendons and your what? Your ligaments. Tendons do what? Connect muscle to bone. Ligaments connect what? Bone to bone. So if you'll go back over, because we're about to talk about something. The next range of motion is the next thing I'm going to talk about. Know the factors that determine range of motion. Page 287 and 288. Okay. Bursa, of course, is another. I don't think this is on your test, but yeah, Bursa is. Bursa is really a sac. They call it a little purse because inside of it, it's got synovial fluid. You probably heard of bursitis, which is inflammation of the bursa. These freely movable joints that we have, you're capable of having what? Bursitis, okay? Typically you find this bursa, it cushions muscles. So when you have inflammation or if you have bursitis, it's typically that muscle that's inflamed. Because if you look on page 285 of your textbook, are they showing you a bursa? Yep, the ulnar bursa. They've cut it. That green structure is the ulnar bursa. And you can see it's around where you find tendons, where the bones are, or where you're going to find any type of bony protrusion. It's near a joint. You're going to always find what? A bursa. Helps tendons slide more easily over your joints, modifies direction of your tendon pull. If you look in your fingers, you have tendons running all the way down from that bursa, the ulnar bursa, all the way down to what? The tips of your what? Your fingers. Okay? So you can have different types. People that you have the, what do you call it? The student's elbow. People that prop their elbows up on hard surfaces for a prolonged period of time, you get a lot of swelling here. That's the bursa around the elbow that has actually become what? Inflamed. Okay? People that do a lot of kneeling, getting up, stooping, getting up, carrying boxes, things of that sort. I think I had a student in my class the other couple of semesters ago. The housemate's knee. She was saying that her grandmother had a job where she would have to do a lot of lifting, kneeling, and things of that sort, and how her knees would swell so big. That was the bursa around that kneecap that was actually what? Swelling. You can get it in your shoulders. So as we go through this chapter, you're going to see a lot of bursa, and they're typically where those freely movable joints are actually what? Located. So typically, like for example, the shoulder, people get bursitis in the shoulders all the time from overuse. We use our shoulders a lot. And what happens is you have a buildup of calcium deposits there. So when you have the buildup of calcium deposits, you have that pinching sensation that's going on in your shoulder. And a lot of times that's due to what? Due to overuse. bursitis. Has anybody had bursitis in here? I always ask that question. Students say, yeah, my grandmother had it. Anybody in here with gout? We can talk about gout over here too. Some of y'all probably have gout or bursitis. Uh-oh. They're bringing some of these muscles out over here. Because you know the next chapter we're going to talk about these muscles. Flexor carpi radialis. Flexor pollicis longus. Okay, while we're over here, let me just tell you the actions of pollicis means your thumb. Okay? Flexor pollicis longus. Longus means it's a long muscle. You have a flexor pollicis brevis, which means it's a short muscle. Now this one right here has its own little muscle and tendon, okay? It allows you to what? To flex what? Your thumb, right? Flexor carpi radialis. Carpi, of course, I can't see it. That's it right there. This one kind of goes all the way down here. Flexor digitorum superficialis. All of this information, this right here, flexor digitorum superficialis, starts up there, comes all the way down here. Flexor carpi radialis. Carpi means what? Your wrist, right? Okay, it's going to allow you to what? Flex your what? Your wrist, right? Now, flexor digitorum superficialis, and you have a flexor digitorum profundus. You can see that that muscle starts where? In your antebrachium, and it runs all the way down to your tips of your fingers. It's going to allow you to, it starts here, goes all the way down, which means it's going to allow you to flex your wrist, your MCPs, your IPs, everything. Okay? Flexor digitorum superficialis. One is more superficial. Flexor digitorum profundus means deep. One is deep. One is deep. One is what? Superficial. Y'all writing that down? Because on your final exam, I put muscles on the final exam. Final exam is easy. Always easy. What time is it? Well, we talked about this right here. Range of motion. ROM, my favorite. The degrees to which a joint can move. Okay, every synovial joint in your body, guys, has what you call a range of motion. Okay, like your ankle, the range of motion for it is 74 degrees. The range of motion for your elbow joint, of course, is 180 degrees. They're based on degrees of what? Freedom that a joint can actually what? Move. So you guys that are pre-nursing major, you will probably talk about range of motion a lot. Probably when you go on your clinicals or your rounds and you've got one of those nurses standing over you, making sure you know what you're doing. I hope you're going to know how to do your range of motion, right? But you can't force it. Some people have limited range of motion. Some of you have limited range of motion. Some of you probably can't touch your toes because you have what? Limited range of motion, right? And that's the beauty of you guys doing those synovial joints for me, because I always know. That's when you decide on if your range of motion is limited or not. Okay? Some students say, I says, well, do hyperextension of your trunk, and they can barely go back. Hyperextension. I'm like, can you do a back bend? Can barely go back. Okay? You can't even flex the fingers. Like that arthritis or something. Aspect of joint performance, physical assessment of a patient's joint flexibility. Those of you that are going to be working in those nursing homes, you had better not. With those elderly people, because they have, they have arthritis, rheumatoid arthritis, osteoarthritis, any whatever with those joints, you cannot force them to, well, no, you can't. You will lose your job, okay? Their range of motion is going to be very limited because range of motion declines as we age anyway. Like I said, some of y'all probably have limited range of motion. What are y'all, like 20, 21 years old? But anyway. So here are your factors that determine the range of motion. Structure of the articular surface, elbow. This is why I brought this thing in here, okay? So when you do your synovial joint movements for me, I'm going to say do flexion an extension of the elbow. Flexion, extension. Or you can, some students like to do it this way, you know, flexion, extension. You know, just, we can do it in whatever plane. This is the frontal plane, flexion, extension, right? Some students go from extension, the 0 position, to here, which is what? Flexion, okay? So when you flex, how many degrees of freedom do I have when I extend? 108, straight line, isn't it? 180, can't go any farther, can't force it. You will break somebody's, one of these bones, okay? So what stops it? The olecranon swings into, what is this called? Yeah, just like that, kind of locks it in place. Can't go any further, that's it. Boom, right here, all right? Olecranon of the ulna fits into the olecranon fossa of what? The humerus. Also, that's it. Here to what? Here. Okay. So, cannot straighten your elbow beyond 180 because as it straightens, the olecranon swings into what? The fossa. Strength and tautness of ligaments and joint capsules. Stretching of ligaments increases what? Range of motion. Pilates increases your what? Flexibility. Okay. Pilates is good for you. Stretching of your ligaments increase what? Range of motion. Dancers, gymnasts. Look at that girl at the beginning of your chapter. They have long, very extensive range of motions because their ligaments have been stretched to allow them to do all of those funky moves that they can actually do. People that are double jointed, they have unusually long ligaments too, which means they have a pretty diverse or weird range of motion going on with them as well. Double jointed people have longer slack what? Ligaments are really, really long from stretching, you know. Strength and tautness of ligaments, the ACL, anterior cruciate ligament. What does your book say about the ACL? That's my favorite ligament. The ACL. Okay. The knee is another case in point. In kicking a football, okay, we are kicking a what? So we're going from flexion of the knee to what? Extension of what? The knee. 180 degrees, that's about it. Okay? The knee rapidly extends to what? 180. Just like this one right here. 180, the elbow, right? You kick a football, that's it. 180. ACL stops it, prevents injury. Its motion is limited in part by a cruciate ligament and other knee ligaments described later. Gymnasts, dancers, and acrobats increase the range of motion of their synovial joints by gradually stretching their ligaments during what training. Double-jointed people have unusually large range of motions, blah, blah, blah. People that are, those acrobats, gymnasts, dancers, they're more likely to have dislocation of joints because of those really, really long ligaments, and they're kind of thin. They're not as taut and strong, but they're more common to have a complete or a partial dislocation as well. So the ACL, guys, attaches, where's the tibia and the fibula? It attaches the tibia to the fibula. It's called the ACL because it's anterior. You have the PCL, which is posterior. It looks like a little X crossing over. One is on the front, one is on the back. ACL, the PCL. PCL is not a common injury. PCL is called a dashboard injury. A dashboard injury, you know, if you're in your car and you're on that front seat and, of course, the car comes to a really quick stop and your knee goes jamming into the dashboard, you can tear your PCL. So that's why they call it a dashboard injury. You got to know is ACL on here, the role of anterior and posterior cruciate ligaments in joints and arm or what? Bones, okay? Now, the ACL, guys, is going to stabilize that knee joint because it's more what? Anterior. So you have your knee joint here, the patella, and the ACL, of course, is going to kind of help hold it in place as well. When you stand up, So when you guys stand and you're about to walk out of here, the ACL pulls really tight to allow your legs to go into extension. All right. On page the ACL and the PCL is on page 302 of your textbook, the textbook reading. But they have a nice picture of it on page 304. It kind of looks like an X. They're showing you the anterior ACL on the anterior view, and they're showing you the PCL on the posterior view. Okay? ACL, PCL. Okay. On page 302. These ligaments cross each other, second column under letter D, the posterior view, cross each other in the form of an X, hence they are called the ACL and your PCL. These are named according to whether they attach to the anterior or posterior side of the tibia, not for their attachments to the femur. When the knee is extended, the ACL is pulled tight. Prevents hyperextension. The PCL prevents the femur from sliding off the front of the tibia and prevents the tibia from being displaced backwards. The ACL is one of the most common sites of knee injury. ACL tears. Kids are getting ACL tears. Okay. So also the ACL prevents hyperextension of your knee. Another thing that prevents hyperextension, guys, is going to be the semimembranosus of your hamstring. If you kick, you can feel the hamstrings tightening up. All right? So typically when students do these movements for me, they're really fun. I love them. It's my favorite lab exam, by the way, because you get to perform for me. But yeah, when they're doing those movements, they'll come to class the next day. I was really sore the next day. I'm like, that was a good thing, right? Yeah, your muscles will probably be sore because you will be using a lot of your muscles on that day. So make sure you come to class, soreness or not. But if you use those muscles enough, you won't even recognize the soreness. It's called endurance, right? Knuckles. What are these bones called here? Angela? Metacarpals, right? And these are This is like the head of the metacarpals, which are called your knuckles, okay? Strength and tautness of ligaments. Your MCPs are called the MCPs. This is it. 90 degrees. It's called the rooftop, okay? If you try and go past 90, what's happening? What's going to happen? I want you all to, okay. It's hot in here. They need to turn the air on, and it looks like some of y'all are about to fall asleep in here, because that heat will make you fall asleep. And I got that on recording. But anyway, do this, all of you. I want you to do this. And try and, don't bend your fingers, don't do that. Try and go down. What's happening? No, your wrist is not supposed to be bending. You're supposed to be flexing your MCPs, honey. So, it's what? It's kind of hard. It's getting right. That posterior ligament here prevents you from going even further, but you can't compromise by doing this. No, we're trying to flex your MCPs, okay? Now what's going on with this ligament here? What does your book say? These right here, they're getting really, really tight and taut, you know? And you do want to flex your wrist, but you're not supposed to. And the ones on this side, they get really, really loose and slack. Why? Because it's preventing, this is about it. 90 degrees range of motion for the MCPs or your knuckles. That's it. Can't go any further. You got it? Actions of muscles and when I flex my elbow, okay, guys, do this. Do flexion of your elbow. Which muscle allows you to do that? Kawani Grace. She was like, when you do this, what muscle allows you to do that? So when you flex, kind of look, flex. Which muscle? The what? All right, pre-nursing, OTs, PTs, athletic trainers. Where are your biceps located? Palpate. Yeah. Because you can feel it tensing up, right? When you do that. When you extend, what muscle is working? They're back here, right? Exactly. Biceps, triceps. So when you do that movement, you're going to have to palpate. I'm going to say, okay, palpate, palpate, palpate. Right? So yeah, the biceps brachii, which is a very, very important, that biceps brachii, guys, is really important because what it does, the tendon from that biceps brachii wraps around the head of the humerus and holds it in the glenoid cavity. Okay? So it really kind of prevents shoulder dislocation. People suffer from shoulder dislocations all the time. And we're going to talk, I think that's is that on here? Know which joints are no. Yep. I think it's on your final exam. The most commonly injured joint in the body is the shoulder. Shoulder dislocation. And it normally affects the acromioclavicular ligament. Something heavy, you're trying to reach up and pull something down, it falls on your shoulder, and this is what happens. The head of the humerus slips out of the glenoid cavity. Okay? And of course, the acromioclavicular ligament is up here, which means you're going to tear that ligament, which is right here because something heavy has fallen on it. So the first point of contact is going to be the acromion, right? So, yeah, people get shoulder dislocation. You can have a partial shoulder dislocation, or you can have what? A complete shoulder what? Dislocation. Okay. I think that's it. Muscle tone. State of tension maintained in resting muscles. Nervous system monitors your joint position and what? Muscle tone. That nervous system is something serious, guys. That brain is going to allow you, when that stimulus goes up to your brain when you're performing these movements for me, that motor neuron is going to allow you to what? To do the movement. So when you have muscle tone, it's like our muscles are constantly in a state of tension. They're not just completely relaxed, okay? So you're going to have a partial, I like to say a partial state of what? Contraction is going on with muscle tone, okay? Muscle tone, which serves in many cases to stabilize what? A joint. Muscle tone stabilizes what? A joint. Okay? So we're going to stop here. You got to know multi-axial and monoaxial joints, which are on page 288 under axis of rotation. Now joints, they're basing it on the planes that the joints can move in, the transverse plane, the sagittal plane, or the horizontal plane. Multi-axial, multi means that particular joint can move through all of what? The planes. Mono can only move through what? One plane. Biaxial moves through what? Two planes. Make sense? Yeah. All right. So, any questions about anything? Know the factors that determine a range of motion. So you know what a bursa is, right? It's almost time for the next exam. Spring break is over, people. I'm glad to see some of you in class today. Some of y'all missed my quiz the other day, too. No points for you. Hey guys, try not to miss anymore unless you're in the hospital half dead. All right. day.